Welcome to Pediatric Pioneers, a MedBridge podcast where we conquer challenging topics for the pediatric therapist through conversations with pioneers who have blazed new trails in our practice. Our aim is to deliver actionable takeaways for practitioners like you. To receive continuing education credit for this episode and access bonus resources, make sure you check out medbridge.com. Hello, I'm your host, Nicole Quint, and I'm an occupational therapist with over 20 years of experience in practice and academia, specializing in pediatric practice and the improvement of occupational participation and performance through my expertise on executive function, visual perception, social emotional learning, sleep, and sensory processing. It is my passion to support pediatric therapists like you so that you can best serve the families under your care with evidence-based practice solutions, easy to implement advocacy approaches, and new ways to lean into your skills within the challenging pediatric landscape. Today, I'm excited to be joined by Dr. Sarah Schoen, Director of Research at STAR Institute for Sensory Processing. She's an expert in the area of sensory integration and processing. We'll be diving deeper into this topic, including recent research and actionable takeaways you can incorporate into practice immediately. Welcome, Dr. Schoen.
Well, thank you for having me, and hello, everyone. I'm excited to be here.
Great. Could you get us started a little bit by sharing more about yourself?
Absolutely. Well, I have been an occupational therapist for almost 40 years, which seems like unbelievable to me when I say it out loud. But I started my career in New York City, getting my master's and my PhD at NYU, and becoming an expert and an instructor in neurodevelopmental treatment. So my focus there was working with premature infants and toddlers, as well as working with preschoolers with autism. But after getting my PhD and wanting to do research, I got a position as a postdoctoral fellow at the University of Colorado in Denver under the mentorship of Dr. Lucy Jane Miller. And after completing that training, which was 2 years, I was able to assist in opening the STAR Center, which later became the STAR Institute for Sensory Processing. So I've been blessed to have a very diverse career. I've conducted a range of studies, including physiological research, which helped to differentiate children with sensory processing challenges from other clinical groups, as well as treatment effectiveness research on the STAR frame of reference. I'm particularly proud of being the first author on a systematic review that was conducted demonstrating the effectiveness of air sensory integration for autistic children 8 to 12 years of age. And I'm currently the director of research at STAR, as well as an associate professor in the occupational therapy department at Rocky Mountain University of Health Professions. And I continue to explore methods to characterize physiological arousal in children and adults, as well as studying clinical outcomes related to participation in our mentorship training.
I'm a graduate. Yes, and we're really excited about the SP3D assessment tool that's coming out eventually. And, I think it's interesting that you're a researcher and bringing that background here to our podcast. So can you tell me a little bit more about what initially attracted you to sensory integration and how your passion for that topic and the research involved has evolved over time?
Yeah, it was always a part of my work, even when working with children who had more neurodevelopmental and neuromuscular kinds of challenges, especially when working with premature infants. And as they develop, we see more of those sensory features interweaving with their motor challenges. But, it really all started on my pediatric field work. And at that time, you were required to do 3 fieldwork experiences, not just 2. And so I did a specialty in sensory integration, and I was sold. I mean, this was like, home, right? I think a lot of us feel that way. And then in my first few years as a clinician, I was able to hear Dr. Ayers speak at a conference in Boston in the 1980s when she presented some of her formative formulations and conceptualizations of praxis and dyspraxia. And that's when I think I just got hooked on the research element and wanted to follow that path.
Right. And sensory to me is such an important topic. I'm a pediatric therapist and academician. I call myself a pracademic. But I think sensory integration is our wheelhouse for occupational therapy. It's our niche. It's our specialty area. A lot of us really feels very strongly about it. So I know it's an important topic to talk about. But I wonder, what questions should we be asking as clinicians? Is there anything we should be questioning about sensory integration, in practice as practitioners? What do you think?
Well, I think there's been a really important evolution in the way we talk about sensory integration, sensory processing. All of these sensory functions really are foundational and critical to our interaction with the world. So to not address these processes seems to be a huge omission in both pediatric and adult practice. So I think embracing that component is really critical to what we do as clinicians, because we're all sensory beings. We're integrating sensory information on an ongoing basis throughout the lifespan. And coining terms like sensory health and wellness are really validate the sensory component, because it is what gives us our sense of self and our sense of agency in the world. It's so formative and fundamental. It's really how we attach meaning to our life experiences. So I think it's really important to think about these sensory processes, but also to think about them across a continuum. And I think that's what's coming out more and more, is we're not saying that sensory differences are bad, or that everybody we all have sensory differences, right? We all have our own unique styles and features that define who we are. But what we need to get good at, maybe even better with some new tools that are going to be available, is to determine when those differences are impeding our quality of life, so that we can make informed decisions about when intervention is warranted and when it's not. We have full respect for the neurodiversity approach, and that, sensory differences oftentimes enhance people's quality of life. And so we really have to think, when do these aspects of ourselves become challenges, and ask, are these sensory features or differences impacting the individual's daily life activities, their routines, or any other aspect of their quality of life? And then we say, what can we do to support this individual?
Yes. And I think, the environment is always changing, and so we have to keep up with the demands from a sensory environment perspective as well. So, I do think it's exciting that we have new tools to use, and thinking about it from that influence on occupations. That meaning piece is so important. So thinking about that and knowing that you're a researcher, what does the recent research tell us? Can you give us some highlights from the most important takeaways from what you're seeing and doing out there?
Sure, absolutely. I mean, I think that the research has really exploded over the past 10 or 15 years. And I do want to acknowledge a lot of the funding that we got at the Star Institute through Dr. Miller's connection with the Wallace Research Foundation was responsible for jumpstarting that across different professions. So both within and outside of OT, we are seeing that explosion. We now have better information that shows that sensory features may underlie some emerging mental health conditions and co-occur with other mental health diagnoses, both in adults and in adolescents in particular. This is being documented in the literature that these sensory differences are actually present and affecting occupational performance, as you said, through the lifespan in terms of emotional regulation, problem solving, attention abilities, as well as things like skill performance and interpersonal relationships. As I mentioned in the beginning, we know that occupational therapy using air sensory integration is effective for autistic children ages 8 to 12 years of age. But we also know that there's emerging evidence. Look, there's always need for more, right?
Right.
But we do have evidence that sensory issues can exist independently of other diagnoses. We know that sensory integration intervention can be effective for children with these idiopathic sensory issues, both provided in the clinic as well as in a school setting. And more is coming out about the importance of collaborating and educating both parents and teachers as the change elements that are going to support our intervention. And also, interestingly, the role of interoception and our knowledge of how interoception links to sensory-based interventions, how it's a critical component of our intervention, because interoception really is, is how we encode our experiences in our body. So it's highly linked to emotions, which are encoded in the body, the brain-body connections that support, as we were talking about earlier, our sense of self and our sense of the world. So there are both visceral and somatic interoceptive experiences that contribute to our body awareness, to our emotion regulation. And that's how the brain makes meaning of these sensations. So when those signals are reliable, we experience a felt sense of safety, because it's consistent, it's reliable, it's accurate. So those body signals convey our current state as well as encoding those memories of past experiences. But when those signals are unreliable, we can feel insecure, emotionally unstable, and oftentimes even cognitively challenged.
And I know, I remember back in the day, there really wasn't a lot about interoception until I started taking the mentorship and feeling like we were kind of like, what do? We know there's something here. So it makes me really excited to see all the work that's being done with that and more tools for everyone. And
I think just to that point, I think there's more and more being written. There are assessment tools that are being developed. And from an intervention standpoint, they're integrating with both, many of the body, bottom-up approaches of sensory integration, as well as some top-down, so that there's really this balance of how can we maximize that experience and solidify those interoceptive abilities.
Yeah, and that's really important. So, knowing you're this prolific researcher, we know the STAR Institute now has been focused on increasing evidence to support sensory integration and sensory processing approaches. Are there any important longitudinal studies or other studies out there that show that sensory integration is an effective frame of reference? I know earlier you talked about with autism, but is there anything else that we could use to know about how it links to effectiveness in treatment?
Yeah, I think that's a great question, and it's one that there is a lot more room for research. Some of the older research is very much, of course, outdated, but there was a recent study this year that I think is useful to discuss. It appeared in the American Journal of Occupational Therapy, and the first author is Dr. Victoria McQuitty. And the title of the paper was Long-Term Impact of an Occupational Therapy Intervention for Children with Challenges in Sensory Processing and Integration. And I think what the hallmark of this paper that's really most important is, yes, they provided therapy 3 times a week for 6 or 7 weeks, and they did their pre-test and their post-test outcomes, but they also followed up with the kids 6 to 12 months later. And that allowed them to look at the same outcome measures, as well as talking to the parents to see if they felt that the gains that their children had made persisted over time. And while there wasn't necessarily a gain from post-test to those 6 months out, they maintained those gains that they had. And the parents also reported that those improvements were sustained. So I think that it speaks to both the importance of the one-on-one intervention, but also in this study, the caregivers were active play partners and actively engaged in treatment sessions, as well as thinking of how to measure change beyond the time that the kids are in therapy. And you know, you and I have talked a little bit about how little we know about sort of this component of intervention we call dosage. You know, what is the ideal amount? Yes, in this study, they were getting therapy 3 times a week. I realize that's not always feasible in various settings. We oftentimes discharge kids with the assumption that they have reached the level that and achieved their goals. But do we know, you know, years later, at the STAR Institute, we can have kids come back for boosters. And so we do more of a kind of short-term burst. But even for us, you know, we need to all of us as clinicians need to do better jobs at checking in with the families and following up with them and seeing how they're doing and documenting that so that we can, in our own clinic settings, be better able to report on what might be the best dosage for our clients.
Yeah, and also thinking maybe episodic care model is a good way to go with the dosage, and those follow-ups show that this is working and maintaining at least, but when there's that change, maybe they need to come back and so I think that's a really important takeaway. The one thing I really liked about this study as well was that they used the COPM and they used goal attainment scaling. And so I like that there was an occupation-centered focus. And then they had the goal attainment scaling, which I think is so important. And then, of course, the family-centered approach, which is also very important.
Yes, totally agree. And I'm a huge fan of goal attainment scaling. And it you know, for those of you who aren't familiar with it, it really is based on parent priorities. It is occupation focused. In fact, I'm in the process of analyzing some data from about 60 clients who came to STAR to see what are the primary occupational areas that parents come to a clinic for the support of intervention.
Yeah, and I think that's really exciting to see what comes out of that. So, and goal attainment scaling makes a huge difference. It really does.
Yeah.
And so if, you know, anybody out there, I recommend you take a course on it or learn how to do it because it can be really helpful. So, you know, on that note, how do we translate that research into our practice as occupational therapy practitioners or even anyone else in working in pediatrics? And I say pediatrics, this podcast is Pediatric Pioneers. However, pediatric children, that's what we're talking about, grow up, right? And when you have these, your sensory features grow with you. And I know that that's kind of something that we might talk about a little bit later, is it maybe not just children that we're talking about, but are there certain patients or clients or even diagnoses or conditions for which the research that you're seeing and all the results that you're seeing would be most appropriate?
Yeah, that's a great question. I think the first step that everybody needs to realize is that in order to determine the need for intervention, we need to identify those participation or occupation-based challenges for which the individual seeking support. We talked about those sensory differences and features that may be indeed strengths to many individuals. But in addition to those occupation challenges, we want to do a comprehensive assessment of sensory integration and sensory processing, and then suggest the link between sensory sensation and daily life functions. So we call them impact statements when we write our assessments. I know Dr. Schaff has also used the term data-driven decision-making. And both of those are really ways of making hypotheses that link the sensory component to those presenting problems that a family or an individual, as you said, with adults are coming to you for services. I do think that it is important to have the assessment to be sensory specific. But we also want to make sure it's not just a parent or teacher report measure. Those are important additions because they give you more of a longitudinal perspective rather than, a moment in time that's captured when you have the individual in your office or, in the assessment. So both are needed, but I think it's important that just a report measure is not a comprehensive assessment. In terms of for whom it would be most appropriate, we've seen a burst in the attention to autistic children, and the fact that the sensory reactivity piece is now part of the diagnostic evaluation, I think speaks to that. But again, I will emphasize the fact that there are many autistic individuals who say that that their sensory features are not interfering. And so it has to be warranted. But we also see children, and we'll talk a little bit about school-based, who have social, emotional, and behavioral difficulties, oftentimes that are manifested in the school environment, that are interfering with their access to the education that they're receiving. And we see adults and adolescents that have mental health symptoms or frank diagnoses that also have an underlying component. Within the occupation based concerns, we see a lot of relationship issues. We see that across the lifespan. We see adults and adolescents who feel isolated and withdrawn. We see kids who have difficulties getting along with peers. But we also see a lot of posture and praxis differences that interfere with those individuals engaging with their peers or forming meaningful relationships.
And I think that was previously maybe overlooked or under considered. People weren't really looking at that as much as they are now. So that's really important too. And looking at the mental health piece, I think, is an exciting area of potential research as well.
I think so. I think because, there's so many different scenarios of oftentimes being when an individual is placed on a medication for a mental health condition and the medication doesn't seem to be working. Sometimes that's an indicator, but sometimes the medications can actually support the child or the individual's ability to access the occupational therapy program. So I think the way we can engage and support mental health across the lifespan is an opportunity that's still growing.
And thinking about some of the research that you were talking about in this idea of, obviously we're just talking about all these different conditions and just also how it's impacting their life, whether it's the quality of life, their occupational participation and performance, as well as you were talking about routines, all the things that we really look at as occupational therapists. I'm curious, all this access to information that you have as a researcher and having your pulse on what's going on, how do you see all of this playing into how we could work with somebody in a therapy session? I'm taking all this information. We're always saying we need to do evidence-based care, use best practices, but when it's coming at you in all these different ways and some of it's not really figured out and some of it's kind of figured out, how do we take this into a therapy session? And I'm thinking about this from not only the intake and the evaluation, which you talked a little bit about, but also the intervention process.
Yeah, I just feel like everything that I look at in terms of the literature and what makes the package of an OT program most effective is the collaboration. I think I see it in the literature around in school-based practice when you can collaborate with the educational team and the teacher in particular. And I see this in the clinic when we can collaborate with the family and engage the caregivers in the intervention process, identifying their priorities, respecting their individual choices, and imparting knowledge. Even though we've got that one-to-one engagement, we so often talk about therapy as sort of having three relationships, right? It's you with the child, it's the parent with the child, and you with the parent. And that's that triad, so to speak, should be really ongoing in terms of the intervention process. And then I think, this idea of, I'm not sure how to phrase it, but tapping the child or the individual's, unique interests and motivations, that this is something they want to do, not something they have to do. And that is, very much the art of therapy.
It is.
Right? I mean, right. Dr. Ayers was gifted in that when air sensory integration, was first popularized. And then, I think many of the relationship-based interventions that complement air sensory integration that might, have started with like DIR floor time approaches really have that inherent respect for connecting, that attunement with the child or the individual who is in the intervention and the family. I think all of those pieces are probably as important as the actual sensory-based or sensory integration kinds of activities, because they all meld together in terms of producing change.
Right. And I think, when I'm thinking about what you're talking about, this is really the crux of occupational therapy. If we're saying we're occupation-based therapists, and we had a guest on earlier, Dr. Wendy Staub, who talked about this, is that, we have to understand that what's meaningful to them, what's purposeful to them at that deep level, which is not always easy to get from some kids, right? Yeah. And so sometimes you're relying a lot on the parent, and that's why that relationship's, important with the parent, but you're really having to learn it in the way that child can communicate to you. And that takes some time and some intention. And I love that word attunement, because I think that's really where it's at in this process, because sensory for some of these kids is scary. And for some of these kids, it's very exciting. And some of these kids, it can go either way. So we have to have that relationship. I think that's the gift of being an OT. But
yes, and I think it's important that it doesn't mean that you have a kid come into your therapy space, wherever that might be, and dictate everything and run around and, for, 45 minutes or an hour. Because that's also that our art is shaping that experience so that you're also providing them with that just right challenge based on their sensory integration features, whether it be postural praxis, or modulation based, that they're still learning and developing, not just aimlessly or, I don't mean aimlessly, but that they're not the ones that are, driving the whole, the what you're doing. It's a collaborative experience, I think is best
I think
stated.
Child-led sometimes makes people think that the child leads the whole situation, but really they just think they are.
Right, exactly. Right?
So how do we address sensory needs clinically, whether it's in home health, whether it's in the clinic, whether it's in a hospital setting? Because you were even talking about, neurodevelopmental diagnoses responding well to some of these sensory approaches versus how we address them in the school-based practice. Because obviously those are two very different systems and contexts. But these kids spend a lot of time at school. And so is there a difference on how we should be differentiating sensory as OT practitioners in these different arenas?
Yeah, I think that school-based practice is really a place for a lot of growth and expansion. I have been really fortunate to be involved in a project that involves developing guidelines for clinicians in school-based practice regarding the provision of service across the tiers based on the principles of AIR sensory integration. So, if we think about tier 1, we can offer education and trainings for staff and administrators about sensory integration theory and applications to the school environment. And so this helps to develop more of a collective knowledge, base and the creation of sensory environments that can support the sensory needs and preferences of children across multiple school contexts, right? And tier 1 can be delivered to multiple classrooms and help students even better understand their own sensory preferences and differences and play a role in their success in school. At tier 2.
And the teachers will know what their sensory is and have more buy-in, right?
Exactly. And how there's maybe certain conflicts about what their sensory preferences are versus their students, right?
Right. If I'm auditory sensitive and I have somebody who's really loud.
Yep. And that, I'm sure that happens a lot. But if you know what your triggers are, I think it can make you better teacher and better able to accommodate to the diversity within the classroom. And I've always thought, being a teacher is probably the hardest job on the planet.
100%. Yeah.
But in tier 2, we're talking more about small groups, more specific teacher consultation. But even there, we can align with the principles of AIR sensory integration, such as providing sensory opportunities that address constructs related to functioning in the classroom, like being alert, having good postural control, being able to plan and sequence the routines and activities within the classroom. So we can still design just right challenges and support the kids' intrinsic motivation through these small groups of students with carefully planned sensory adaptations to support success and maybe activity modifications that also maximize their engagement in the classroom. And then, of course, tier 3 focuses more on that one-to-one sensory integration intervention. And, making sure that when we do that provision, that it still includes that teacher consultation. We need the carryover into that classroom and generalization. And, also making sure that those adaptations still exist for that child in the classroom. So it's the direct intervention plus these other pieces that are layered into the child's program. And always remember that we're supporting the education-related goals of the student and recognizing the importance of that change for the student's success in the school and keeping the family involved in that as well. So it really is a multifaceted approach. And it's across this continuum for the child. So, I recognize that there are a lot of obstacles, and we can talk more about that in different settings. But I think it's also a wonderful opportunity that is increasingly available to occupational therapists across settings.
Yeah, and you were talking about some of those the barriers being kind of significant with practice, and I'm curious in the with these guidelines for school, what are some of those barriers that you're seeing in school-based practice besides the teacher buy-in or teacher awareness?
Yeah, well, time is a big element that I think a lot of OT practitioners identify. Time to consult with the teacher, time for assessment of the students. But, it runs the gamut from space, equipment, and resources, training opportunities, having the appropriate supervision, getting support from administration. I mean, these are not small obstacles, and we're not saying that every school or every school-based practitioner will be able to address all 3 tiers even. But it's something that we feel, and I certainly feel very responsible at this stage of my career to be able to say, can I be a change agent? How can I help in creating educational programs that are affordable, that are accessible to school-based practitioners? What kind of networking can we set up for school-based practitioners to get the supervision that they feel that they lack? How can we just, adapt, some of the equipment or space? I realize not every school has a playground, but and nor can they work necessarily all year round. But can we access that? Can we use the gym when it's not being used for PE? Again, we aren't saying that everybody can do this or all of it at once, but can we set up these goals and work towards making this feasible and realistic for more practitioners who are working in schools?
That's a very big picture approach. I mean, that's kind of scanning your entire situation and saying, where can I make change? And I think that we're good at that as OTs. I mean, we drill down because we end up having a child that we're working with, and we focus on that child. But I think what you're saying is really thinking about this data, your own kind of occupational routine and how you're doing things and how you could make changes in that system that could have big carryover with your practice. And I know that you really speak a lot to that collaboration piece with the teacher, with the family. And I know that's hard in school-based, but also collaborating with other practitioners, the mental health practitioners, physical therapists, speech and language pathologists, if they have a counselor at the school, those kind of collaborations could be part of that big picture as well.
Yes. And this big picture has many clinicians and educators at the university level who have been leaders in this. So I am just one cog in the wheel to support this mission, but I have colleagues and collaborators, and I'm not going to, mention specific names now, but they are the next generation that really is going to move these goals forward.
Right. And that's a good point. People can reach out to that network, and see if they can get some help and support as well. That's a good point. So, this podcast is all about having actionable takeaways. And we've been talking some research, we've been talking big picture changes and being a change agent, but talking maximum impact. What would be your top 3 actionable takeaways for practitioners that they could put into their practice immediately?
Great question. And of course, I want those takeaways because I think the evidence is there. Occupational therapy using air sensory integration is effective. There is evidence from research with autistic children, and there is emerging evidence for children with idiopathic sensory issues. There's emerging evidence for effectiveness in school settings and with adults presenting with co-occurring mental health concerns. I believe that treatment in schools should be a priority. Sensory health and wellness impact all children's success in school. And educating parents and teachers, I think, is a critical component of any program because we're never going to see that carryover if we don't build knowledge and foundations from the people who are spending, 100% of the time with those kiddos and adults who need to learn about themselves.
Right. And then I know you might have a 4th one. I asked for 3, but I know there's a 4th one.
You're right. There is. I think we need to consider integrating our knowledge of interoception into our treatment. There's a growing range of coursework and workshops that are emerging to support how to integrate, as we said earlier, the bottom-up and top-down components that really support interoceptive awareness in the formation of that sense of self, of agency and impact in the world.
Right. And I think that's a really important 4th one to add, for sure. That's some really great advice. And I think those are things that people can definitely put into action right away. But I wanted to, I always want to support folks by talking through the best way that we as OTPs, occupational therapy practitioners, address that call to action, right? And so how can we advocate for sensory integration effectively while overcoming cynics? Because there are cynics out there. There are people who will say they don't believe in it. And I always tell them it's not Santa Claus. You don't get to believe in it or not believe in it. There's evidence to support it. But there are going to be cynics out there, and that can be another barrier that people have to overcome.
Yeah, that's so true. I mean, I guess, my go-to is always the research because that's my background. But I do think that, in any clinic or setting, you could have, your little spiral-bound notebook that has the articles that support occupational therapy using a sensory integration approach. There are systematic reviews that have been conducted by the American Occupational Therapy Association. There also are single studies that show change within specific settings and with specific populations. Now, one could argue that, you need a body of literature, and that's what is growing, but these single studies are still a first step, but I also think that there are so many opportunities that practitioners have to create their own databases of outcomes. And you don't have to be a researcher to implement, pre-test data and post-test data. And so when you're meeting with a local pediatrician or a school administrator, can you say, I've been collecting this information over the last few months or maybe even across the year, and I want to show you, I have 10 kids on my caseload and they all improved in these areas, and then of course we also talked about, the clinic therapist who could maybe do the follow-up longitudinally
6 months
with
later,
their
a year
clients.
later.
So, I maybe I'm biased because I am a researcher, and I would be happy to consult with any clinician out there who wants to set this up for themselves, because it's really powerful what we do. And we're not as skilled at documenting what we do and what works, and sometimes what doesn't work that we can learn from to improve that. So I always think of, change is slow, right? But can we create evidence, one client, one student, one adult at a time? We did just a follow-up with some adult clients who came to STAR. Now we did, I think it was 10 phone calls. You could do 5 and say, what was most meaningful about your time with us at STAR? What did we do well? What could we improve on? And we learned so much from that. And yeah, we were able to publish that. You don't have to publish it to be able to incorporate those changes. What did those adults want? The stuff that was most meaningful was the physical activity that we got them engaged in, as well as, and use of their free time, and being able to access their peers or relationships, their colleagues. That was what was really the networking that got set up because of being involved in the intervention. So I think you have to look at what your setting is, who are the people you're serving, and how can you best meet their needs with the evidence you have, with your own clinical wisdom, and then, put it down on paper.
Right. And you brought up the adult example. And I want to pick your brain on that one a little bit, because this is an area of such need. Because, pediatric therapists, sometimes they're just stuck to the confines of pediatric parameters. Medicaid ends at this age and school ends at this age. And therefore, we tend to see kids under 21 years of age, right? But what happens when you have adults seeking, and I have worked with this in my own practice, finding that adults have a really hard time finding somewhere to go. So could you give us kind of just a little bit of guidance on how a practitioner could bring, the adults into their practice, and what that would maybe give us like a adult example of what treatment would look like?
Yeah, I think that's important to recognize that there are a whole host of individuals out there that might have a history of some mental health concerns. I think we see anxiety and depression are probably most common. And with that comes some emotional challenges, a sense of isolation, being withdrawn or pulled away from potential relationships and friendships. And this can come from your collaboration with mental health practitioners. I'm not saying that every adult with a mental health condition is necessarily somebody who needs occupational therapy or has sensory differences. But I think the more that we educate sort of the mental health team that's working with clients, they may be our first avenue into, I think, them identifying a person that they want you to help support. And then it starts with a comprehensive evaluation. We had a client who was in her 30s, a woman who had a history of anxiety and depression, complained of auditory sensitivity and always getting lost when she'd go out. So if you've got those two symptoms, you're probably going to stay at home most of the time. But once the sensory issues were confirmed, then what we had to do is help educate her to see how her sensory challenges were linked to these presenting problems. And then it's a collaboration with the mental health team and a combination of those multisensory experiences, like we were talking, bottom-up approaches and top-down cognitive strategies. And I think, that understanding the sensory piece for many adults is such an aha moment. But like I said before, the kinds of sensory motor activities that we use, and while they're different with an adult, you might use a treadmill or you might use weights to get your proprioceptive input. But the physical activity and exercise was one of the pieces that was most meaningful to this woman. It helped her with her emotion regulation. And like I said, then the top-down cognitive understanding and getting attuned to her interoceptive awareness of differentiating emotions for herself by differentiating how she felt was so much a part of her learning process that allowed her to be more open to engaging in the world.
I mean, that's a great example. And I think a lot of therapists that are out there could start to feel more comfortable in working with adults. And I know there are more tools out there for assessment. We talked about the study that used the COPM and goal attainment scaling. You could use that with adults, as well as the sensory observations and then different checklists and eventually the SP3D. So I think this is an exciting time to see us meeting the needs of adults out there with sensory needs. And I think it's really exciting.
I agree. And I'm glad that you mentioned the SP3D, because when it does get published, hopefully next year, we know that it's going to be, there's a whole adolescent adult form of the test, so you can use it throughout the lifespan.
Yeah, which is great. That's so needed.
Yes.
So as we wrap things up, we've talked about a lot of things from the research to, call to action, on how to better serve our clients and also bring in adults into practice. So to wrap things up, what final words of wisdom or inspiration would you like to leave with our listeners?
Well, I really think that, I love OTs, and I think that we all really need to trust ourselves, and so trust your clinical wisdom. Research is incomplete and still emerging. So it needs to catch up with your clinical reasoning and your clinical experience. And always seek new knowledge because it's out there and it's changing so rapidly. Trust your client and your client's family. They know themselves. They know their child. They know what they need or want or what their priorities are. And I know I'll sound like a broken record. Collect outcome data. Build your own body of knowledge and literature about the changes in your practice. Try new things, but be responsible about measuring what works and also measuring what might not work, or documenting at least when you see that those things aren't working, and modify. Because we are all doing little mini research projects. Every day we see our clients.
We can all be informal researchers, right?
Yes.
It's really what it is get your metrics. That's what everybody does. You have to have your metrics to show what you're doing is working and to guide you on how you're going to reshape things. So I love that idea. And I know often we'll be like, I don't like research. I'm not a researcher. I think we need to take a step back and say, maybe I am. I could be an informal researcher, right?
Yes, exactly. Well said.
And maybe then people will start to then step into being more of a formal researcher. We would love that too.
Yes, absolutely.
Well, thank you so much, Dr. Schoen. It has been a pleasure. That's all the time we have for today. And I want to thank you, Dr. Schoen, for your insight, for your clinical and research takeaways related to sensory integration and sensory processing. Thank you so much.
Well, and thank you for having me.
Thank you for tuning into this episode of Pediatric Pioneers by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or on your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and complete the quiz for this episode. Pediatric Pioneers also listens to you. If there is a particular practitioner that you'd like to hear from, or if you have a question or challenge that you'd like to explore on this podcast, please let us know by leaving a comment on our Instagram posts or by emailing podcast@medbridge.com.